Good morning. Welcome to In the Trenches with David Cohen. Today, we're going to talk about a quick approach to hypoxia. How do you approach the patient you see in the emergency room or in the hospital? Somebody becomes acutely hypoxic or they're chronically hypoxic. How do you approach this patient? And this is very important to understand mechanisms, because via the mechanism, you could figure out how to treat the hypoxia, and often it involves a lot more than just giving supplemental oxygen. Now, obviously, you want to do a history and a physical exam first. You want to find out they're short of breath, if they have a history of underlying lung disease, if they have a history of underlying cardiac disease. You want to examine them. You want to listen for crackles, for rhonchi, for wheezes. You want to make sure they're not in heart failure. But beyond that, let's get to the fact the patient's hypoxic and say their pulse ox is low. Okay, there are 5 mechanisms for hypoxia. Shunt, VQ mismatch, hypoventilation, increase altitude, and diffusion of blood. These are the mechanisms. And really the 3 that need to be focused on are number 1, number 2, and number 3. So simply, a shunt is blood that's not oxygenated. Blood that's not oxygenated is a shunt. So you're going from the right side of the circulation to the left side without oxygenation. There are 3 types of shunts. There's cardiac, pulmonary, or pulmonary AVMs. So a cardiac shunt is either a VSD or an ASD where it's right to left. Okay, now it could have started as a left to right and then it reversed, so-called Eisenmenger physiology. But it's bypassing the lungs. That's cardiac. A pulmonary shunt, which is the most common, blood's not getting oxygenated. So the lungs could be filled with fluid, as acute pulmonary edema. Or it could be filled with pus, like pneumonia, and blood's going in there and gas exchange is not taking place. That's a pulmonary shunt. An AVM, and these are a lot less common, but they do exist. These are capillaries within the lungs, and they're going from the arterioles to the venules, bypassing the lungs. You can see it with conditions such as hereditary hemorrhagic telangiectasia. Not that common, but that does exist, and maybe you'll see telangiectasias in other parts the body, maybe on the face. And then liver disease. Okay, so people with cirrhosis could actually get these, and they're more in the lower lobes of the lungs. So a patient will stand up and they'll get more hypoxic because you have increased blood going to the lower lobes of the lungs. And when they stand up, they're hypoxic. That phenomenon is known as orthodeoxia. They feel better lying flat. That's known as platypnea, and it's actually the opposite of orthopnea. So these are shunts. Now, what is a VQ mismatch? The definition of this is blood that's not oxygenated enough. Now, this could occur along with shunting. So here you have blood that's being oxygenated, but just not enough. And physiologically, the way you distinguish between a shunt and a VQ mismatch is you give oxygen. If it's a VQ mismatch, the O2 will go up. If it's a pure shunt, it will not. Often you have a combination. Now, this could be due to wheezing. It could be due to atelectasis. Often you see this in combination with shunting, but it's blood's not being oxygenated enough. Now, this is different than dead space, okay? If you have a problem with hypoxia, you have positive flow and negative ventilation. Okay, so if you have a situation where you're not delivering blood to the lungs, you're not going to be hypoxic. Hypoxia is when you're delivering blood, but the blood's not being oxygenated. So if there's an occlusion of a blood vessel, like a pulmonary artery with a large pulmonary embolism, they could be hypoxic, but it's not due to that mechanism. You're opening up shunts, and you have micro shunting and atelectasis going on. That's what goes on there. It's important to make the distinction. There's something called dead space, okay, where you're ventilating but you have no circulation. That's dead space, and the body responds to that by hyperventilation. The third thing is hypoventilation. So somebody coming in, they could be hypoxic because they're not breathing enough. And within the alveoli, you can only hold so much oxygen plus carbon dioxide. If you hypoventilate, your CO2 will go up. There won't be room for oxygen. Okay? And the way you could determine this, besides a blood gas, you could calculate an AA gradient. So the alveolar oxygen, that's the FiO2, times 760 minus 47 minus PaCO2 divided by 0.8. You take this and you subtract the PaO2, the blood gas. This is 713. The FiO2 of room air is 21%. We breathe in 21% oxygen. Okay, so this is actually 150 times the PaCO2. 0.8 is the respiratory quotient, and you subtract the PaO2. Okay, so the increase your CO2 is, if this is up, this difference is down, and this difference is down. And the thing is, patients who are hypoxic due to hypoventilation, they do not have wide AA gradients. Okay, people who have shunning or VQ max matching have high AA gradients. Increased altitude, you know, that's somebody who's high on the mountains. Maybe they're in Colorado or in some mountain where they're inspiring less oxygen. That we're normally not going to see in the hospital. And diffusion blocks add in, they're non-specific. You can see diffusion blocks with emphysema, with interstitial lung disease, and other conditions. These are the 5 mechanisms. These are the big 3. So if you're evaluating somebody with hypoxia, okay, you need to understand what the mechanism is. Now, if you listen to somebody and they're in acute pulmonary edema and they got crackles bilaterally, you're going to assume it's due to that, and you're going to give them diuretics. If you're examining somebody, say an individual with asthma or COPD, and they have bilateral wheezing, and their air movement does not seem great, you're going to assume it's due to that. You know, if you're examining somebody and they're hypoxic and their lungs are clear, that's trickier. You need to make sure they're not hypoventilating. You need to assess their baseline neurostatus, or are they on narcotics or other medicines that would suppress the respiration? Or do they have a pulmonary process going on that will not cause abnormalities on the chest exam, like a pulmonary embolism? And in that case, you need to evaluate for that. But something that could be very helpful is calculating the AA gradient first. And with that, I'm going to stop. This is my brief approach to hypoxia. We are in the trenches. Thank you.